So that brings us to white blood cells. So we'll change gears a little bit. What's the term for white blood cells? Leukocytes. Remember, the leuko means white. So this literally means white cell. The reason we call them white blood cells is because they're not red. The red blood cells are red, right? Because remember, the red blood cells have a bunch of hemoglobin, and that's a red pigment. The white blood cells don't have hemoglobin. So they're more of that kind of translucent color, like a typical cell color, because it's mostly water inside. They just pick up color when we stain them. So when we look at them under the microscope, when we're seeing purple or blue, it's because we've stained them. They're not naturally that color. They are white blood cells. They also differ from red blood cells in a few other ways. They have nuclei, right? So there's a nucleus and organelles present. When we look at them, we'll see that there are all different shapes of nucleus or nuclei depending on what type of white blood cell we're looking at, but there is a very predominant, obvious nucleus present. They're typically spherical in shape, so they're not those flat biconcave discs. Instead, they're like balls, right? They're spheres, and they're much larger than red blood cells. Again, when we looked at the blood smear, you can see, right, that there's lots of little red blood cells and then a big white blood cell. They're a lot larger. The lifespan varies greatly. So a lot of our white blood cells just have a lifespan of days, but they do have the ability to last a lot longer than that. Some of the white blood cells, because they have a nuclei and ribosomes that can repair themselves, have the ability to live for years. When we do the lymphatic system, we'll see that our memory cells, like we have memory T cells and memory B cells, those are the ones that hang around in your body to give you long-lasting immunity. Those ones last a very long time. They have a lifespan of years to give you that long-lasting immunity. So when we look at white blood cells, remember when we looked at our formed elements, what's the most common formed element? Red blood cells, right? Remember, like over 99% of your formed elements are red blood cells. So when we look at circulation, when we look at your blood, there's very few white blood cells, right? It's less than 1% of your circulating blood cells are actually your white blood cells. Most white blood cells are not in your blood. Most of your white blood cells are in either your connective tissue or your lymphatic system. So the lymphatic system includes like your lymph nodes, which I'm sure, if you know nothing about them, you know they have to do with infection, right? Like when you get sick, we palpate your nodes to see if your lymph nodes are tender or swollen. We find them in the lymph nodes. We find T cells in the thymus, the spleen, and then the lymph itself. So most white blood cells are actually out roaming around the body or somewhere in the lymphatic system. Very few of them are actually in the blood. They're really just traveling through the blood to get wherever they need to go. When you look at a typical white blood cell count, it varies a lot depending on the reference that you look at. Our textbook says that there are 5,000 to 10,000 white blood cells per microliter of blood. This symbol is microliter. Your lab manual said milliliter after that symbol. That symbol is microliter. Okay? Milliliter is like length. Different references will be different. Some references will say between 4,000 and 11,000. Some will say 3.5 to 10. So you kind of have to work with the lab you're working with. At your specific hospital or office or whatever lab you're working with, they'll give you the normal value. So just realize that it will vary a little bit, but it's somewhere around this number. White blood cell functions all have to do with really defending the body. They defend against pathogens. What's a pathogen? Disease-causing organism, right? So give me an example of a pathogen. Virus, bacteria, fungus, right? Any type of organism that can come in your body and cause some sort of infection or disease. They also remove toxins and wastes, as well as old or abnormal body cells. So remember we talked about like macrophages removing our old, worn out red blood cells, right? They engulf them, digest them. That's their job, to remove the old cells. This also occurs with our cells that become abnormal. So maybe if our cell gets infected with a virus, it's no longer a normal healthy cell. So the immune system or white blood cells will take care of it. If one of our cells becomes a cancerous cell, it's it's no longer healthy. So the white blood cells should take care of it. So they can remove our cells as well if our cells are no longer healthy functioning cells. But essentially, really, we're just trying to prevent infection and disease. The white blood cells that are circulating in the bloodstream will share a few key characteristics. They have a few key kind of behaviors in common. And the first is that they can migrate out of the bloodstream. Remember, I said that most white blood cells are not actually in the bloodstream, and that the bloodstream is really just for them to get somewhere. Most of them are actually out of the bloodstream, and they're in the connective tissue or the lymphatic organs, somewhere where there's an infection present where they can fight it. So the way that they migrate out of the bloodstream to get to that site of infection is via two kind of conjoined processes, margination and then emigration. Margination is when the activated white blood cell attaches to the vessel wall, because remember, the blood's flowing, right? It's not like just hanging out still. It's moving pretty fast. So the white blood cells are constantly moving. If they need to leave the bloodstream, the first thing they need to do is kind of anchor on to hold still. So they'll attach to the blood vessel wall. So that's just the margination. Then emigration is when they actually move out of the bloodstream. So this is when they literally squeeze through endothelial cells. We haven't done vessels yet, but endothelial cells, guys, are the cells that line vessel walls. So like if you're looking at a blood vessel like this, you'll have little endothelial cells like that lining the vessel. They're normally packed nicely together, right? There's not huge gaps between them. They're normally packed pretty tightly together. But what these white blood cells can do is, they're flowing through the bloodstream, right? And say there's an infection over here. So we release all these chemicals that try and call white blood cells, right? It's like neon flashing lights saying infection, infection, infection. And we try and call all the white blood cells to that area. So these white blood cells that are flowing through the blood first will attach to the wall so they stop moving. And then they actually release chemicals that control the endothelial cells. And they tell the endothelial cells to provide room for them to squeeze through. So they'll release these little local chemical messengers. The endothelial cells will provide a little bit of room, and then that's the actual emigration, so that they can then leave the bloodstream and go into the surrounding tissue. White blood cells also have amoeboid movement, and the way that they move like this, it's not really well understood. We don't really understand very much about how they're able to do this, but amoeboid movement is purposeful movement. They have the ability to purposely roam around and move where they want to go. It's named after an amoeba because it appears to look like the way an amoeba moves. But they do have the ability to do this purposeful movement in the direction that they want to go, which is how it's so easy for them to migrate to sites of infection. Related to the same thing, white blood cells exhibit something called positive chemotaxis. Okay, chemo like chemical, and taxis, think like a taxi, right? Taxi brings you somewhere. So like movement, right? Positive chemotaxis is when the white blood cells are attracted to a chemical stimuli. So that's kind of like these neon flashing lights we set up here, right? If there's an infection, we release all sorts of chemicals like prostaglandins and leukotrienes and all of these chemicals that will attract other white blood cells to the area. Again, that's positive chemotaxis. You're attracting them to the site of infection. And that's how they know that there's an infection. They all need to go there so that they can fight it. Some white blood cells are phagocytic. You guys should all know what that is now, right? What is it? What's that when you're phagocytic? Cell eater, right? You engulf things, you digest things. Neutrophils, eosinophils, and then the monocytes, which remember become macrophages. are all phagocytic. So they all have the ability to be Pac-Men, right? To engulf things and then they can digest them and break them down. Whether that's a bacterium or maybe a cell that's been, infected by something, or fungus or toxin, whatever it is, those ones are all phagocytic. So remember, we have 5 different types of white blood cells. This should all be kind of a review from lab, so we won't spend too much time on it. But we have neutrophils, eosinophils, basophils, and monocytes, and lymphocytes. We can split them up into 2 groups, right? Granulocytes and agranulocytes. Which ones are granulocytes? The fills, right? Because they're filled with granules. So neutrophils, eosinophils, and basophils are granulocytes. When you look at their cytoplasm is all these little dots. Right? These little dots are vesicles. They're granules that are filled with like cytotoxic enzymes and acids and all this stuff that would digest a target. Monocytes, which become macrophages when they enter the periphery, and lymphocytes are called agranulocytes because they do not have that same predominant granule present. So we'll go through each of the types of white blood cells in a little bit more detail than we did in lab. But again, this is really still just a brief introduction. We have a whole chapter where we talk about immunity. So we'll talk about their receptors and the way that they're stimulated and the way they destroy targets. And we'll go through a ton of detail when we do that chapter. This is just very, very brief overview. So neutrophils, are they granulocytes or agranulocytes? Granulocytes, because they're filled with granules. Okay, they typically have a pale cytoplasm with granules present. We also call these polymorphonuclear leukocytes. Okay, a leukocyte is just a white blood cell. Polymorphonuclear is referring to the nucleus that can have many shapes. Remember, in lab I called this a segmented nucleus, and I said that that's the way you could identify a neutrophil, because it has a really chunky nucleus. Like the nucleus isn't nice and round, it's not even close. It's like there'll be like a bead, and then another little chunk, and a chunk, and it's like this super messy, chunky looking nucleus. But that's where this polymorphonuclear name is coming from. Neutrophils, remember, are by far the most abundant white blood cell. What's the blood test called where we kind of assign percentages to each of the white blood cells? Differential, good. So a differential, remember, the blood test where you look at 100 white blood cells and you count them. And you say, okay, 60 of them were neutrophils, right? And then you say 22 of them were lymphocytes. So you're assigning essentially percentages for each of the types of white blood cells. And when we looked at that differential, we saw that neutrophils were by far the most common or most abundant circulating white blood cell. They represent, again, depending on the reference, but ours says between 50 and 70% of the differential. When we're identifying them, they typically have a relatively pale, kind of pale purplish cytoplasm, but again, the nucleus is the easiest way for you to identify that when you're looking at them microscopically. What these granules actually have are lysosomal enzymes and then bactericides. Peroxide, superoxide, these are things that kill bacteria. And then the lysosomal enzymes, remember, like a lysosome is a little vesicle that's filled with digestive type enzymes, right? And remember that it has the ability to digest whatever the target is. So that's the point here, is that these things can kill bacteria, they can digest targets. And we keep them in the granules, we keep them in vesicles so that they don't actually digest the neutrophil itself. They're packed in their little vesicles until they're needed. Neutrophils. When we talked about them in lab, remember we said that they were typically the first to appear at the site of an infection. And this is one, they're super active, but also because there's so many of them. You have way more neutrophils than anything else. So it's most likely that they're going to be the first things to appear at the site of infection. We said that they are phagocytes, right? They're phagocytic. So they do have the ability to engulf and digest pathogens. They also release other chemical mediators that help to stimulate the immune response. They release prostaglandins, and prostaglandins cause inflammation. Okay, remember in lab we said that neutrophils also cause inflammation. It's not just basophils, the neutrophils do it too. The neutrophils will release prostaglandins in order to cause inflammation. And inflammation is protective. It helps to limit the spread of infection. So you try and keep an infection contained in one area by causing inflammation. And then they also release leukotrienes. Leukotrienes will attract other white blood cells to the area. Remember we said, what's that called? When you have a chemical attract something to the area? Good, positive chemotaxis. Right, so that's going to be positive chemotaxis. Okay, so they're normally the first on the site of an infection. They're phagocytic, and they cause inflammation, and they call other people to the area, right? Because they're normally the first there, but they might not be the most effective against whatever the target is, so they start to call everybody else to the area so that anybody who needs to be there can be there to fight the infection. Lymphocytes were the next most common white blood cell. Remember the acronym that we used was never let monkeys eat bananas. So N for neutrophils, right? L for lymphocytes. Lymphocytes will typically represent about between 20 and 30% of your differential. And remember we classified them as agranulocytes, right? So they do not have granules present. When we're identifying them microscopically, the easiest way to do that is by their huge round nucleus. Remember when you look at a lymphocyte, hey, if that's the lymphocyte, the nucleus can be like that. So essentially all you see is this huge dark circle, and then you see very, very little pale cytoplasm around it. The nucleus takes up almost the entire cell. That's the easiest way to identify the fact that you're looking at a lymphocyte. Again, lymphocytes regularly migrate in and out of the blood. We said that this is really common for white blood cells. And when we look at lymphocytes, again, they're very, very rarely in the bloodstream. Most by far, again, are going to be out in the connective tissue and then in the lymphatic system. The lymphatic system is very, very closely related to lymphocytes. Okay, so very, very closely related. When we talk about the lymphatic system, we'll talk a lot about lymphocytes. When we talk about lymphocytes, remember we said that it's part of the body's specific defense system. And we said that it gives us acquired immunity. What this means is that the lymphocytes actually recognize and fight specific pathogens. So you'll have lymphocytes that are active against one virus only. That's all they do. You'll have other lymphocytes that are active against a different virus. Right? That's why you have to get lots of different immunizations. Like one immunization doesn't just cover everything, because you have to stimulate each different kind of lymphocyte, because one lymphocyte will be active against, or one family of lymphocytes will be active against one type of pathogen. They are specific in the way that they work. Also, we say that this gives us acquired immunity because you're not born with them recognizing pathogens. Your other immune system components, you're born with them working as a baby, right? A baby can get a fever, inflammation, macrophages work. But the lymphocytes, you have to actually be exposed to a pathogen before they replicate and produce antibodies and learn how to fight it. Again, that's why we get vaccines, to provide that exposure so that your body can learn how to fight something, to provide that acquired immunity. You acquire it, you learn it, you're not born with it. We have three functional classes of lymphocytes that we'll talk about on the next slide. We have T cells, B cells, and NK cells. That they are all lymphocytes. So T cells, they're also called thymus-dependent cells. That's where that T is coming from. But T cells provide cell-mediated immunity. They actually will kill target cells. Okay, they work intracellularly. They'll actually attach, bond to a cell, and they'll kill the target cell. So we call this cell-mediated immunity. And again, they're direct killers. B cells, or bone marrow-derived cells, give us something called humoral immunity. Humoral refers to fluid. And the reason for this is that they end up working extracellularly. They don't kill target cells directly. The B cells do not kill target cells directly. They work extracellularly in the fluids, right, out in the body fluids, hence being called humoral immunity. What happens is that the B cells will end up, when they're activated, they'll differentiate, right, or mature, change into plasma cells, and then these plasma cells will make antibodies. We've been introduced to antibodies a little bit, right? Remember, antibodies float around, and when they find their antigen, they'll bind to their antigen. And then a lot of different things can happen. We can see agglutination or clumping happen, like we saw with the red blood cells. They can do a lot. They can enhance phagocytosis. There's a lot that goes on there, and we'll talk about all of that during lymphatic. For right now, just know that B cells are humoral immunity, and that they differentiate to plasma cells. Then those plasma cells give us antibodies. Okay, and again, these are all lymphocytes. NK cells are natural killer cells. These are especially active against our body cells that become abnormal. So, for example, cancerous cells is the big one here. When our body cells lose the ability to control their cell division and they become cancerous cells, NK cells are responsible for recognizing that and engulfing and destroying that cell before it's able to become a tumor. Again, this is super surfacey, but we'll go into lots of detail when we do lymphatic immunity. Monocytes are the third most common white blood cell. Again, they're 2 to 8% of our differential. They are agranulocytes. Remember, they're not filled with granules. And the easiest way to recognize them is the kidney bean-shaped nucleus. So their nucleus will typically be shaped kind of like that, kind of like a kidney bean. Sometimes it's a little more U-shaped, sometimes it's a little bit like less curved, but it's relatively kidney bean shaped. Remember that monocytes will leave the bloodstream, go out and roam around the periphery, and they mature into something called a macrophage, right, or a big eater. Macrophages are very, very aggressive phagocytes. So when we look at these, we see that they're really the most aggressive of our phagocytes, and that they can engulf things that are even larger than themselves. So that's really, really impressive. We talked about this when we talked about red blood cells, right? How do we get rid of old red blood cells? Macrophages in the liver, spleen, and bone marrow, right? Remember, the macrophage engulfs that old red blood cell and starts to break it down into all of its components that we then recycle or get rid of. But they do this a lot. They could do this with bacteria. They could do this with any type of old cell or toxin, anything that shouldn't be there. The macrophage can phagocytize. They also secrete substances to attract other immune system components to the area. Again, this is pretty much any white blood cell though. And what did we call that again? Positive chemotaxis. Whenever any of our white blood cells goes to a site of infection, they're going to call other people to the area. There's tons of positive chemotaxis occurring with the immune system. Eosinophils, or they're also called acidophils, represent 2 to 4% of our differential. So remember, these are the ones that look red. They're granules stained like kind of a brick color, like a crimson or red color. They're the only ones that stain that brick color. and their granules they're super, super red granules. They're the only ones that look that way. When we look at this red dye, it happens to be called eosin, so that's why they're called eosinophils. It's an acid dye. They're the ones that stain with acid dye. That's why they're called eosinophils, or eosinophils. So that's where those names are coming from. But remember, just when you guys identify them microscopically, all the red granules in the cytoplasm will tell you that you're looking at an eosinophil. Eosinophils have lots of different functions. They are phagocytic, right? So if we have a bacterium that's already marked with antibodies, it's marked as foreign and something that needs to be gotten rid of, the eosinophil can come phagocytize it, digest it, kill it, get rid of it. But that's not the way that they're most effective. They're actually most effective by releasing their granules. So they release all of these toxic compounds in their granules. Nitric oxide, other cytotoxic enzymes. Cytotoxic, like toxic to a cell, right? Just nasty things that will kill target cells. They're most effective by releasing all of the chemicals and the enzymes from their granules and destroying a target extracellularly, right? Instead of actually taking it in or phagocytizing it. This is why we say that they're so effective against large parasites. Yeah, a lot of parasites are big. They're multicellular organisms. Think of like a tapeworm, right? Worms are big. It's too big for one little cell to phagocytize and take in. So you have to kill it some other way. The eosinophils can go to the area and then they'll release these toxic granules right on the surface. Then all of these substances will go to the parasite and kill it from the outside because it's just too big to take in. So we very closely associate parasitic infections with eosinophils. Eosinophils are sensitive to allergens. That means that we have an increased number of eosinophils in an allergic reaction. Allergic reaction. We talked about that in lab. Remember that the reason for that is because eosinophils can actually counteract or decrease inflammation. All of our other white blood cells, essentially, most things in the immune system cause inflammation because inflammation is protective. So we've got things like neutrophils, basophils. We'll talk about in a later chapter what mast cells are. All of these things are causing inflammation all over the place to try and protect the body. But remember, anytime we start to get away from homeostasis, we've got to have a way to pull back on it and make sure it doesn't go too far. So when we start causing inflammation, we need a way to control it and bring it back down again. And our eosinophils are good at that. They're good at decreasing that inflammation to make sure that we don't cause too much inflammation. So you'll see an increased number of eosinophils in a parasitic infection. You'll also see it in an inflammatory response.
So if you take a medication to treat a parasitic infection, does it encourage your eosinophils?
It depends. They can work all different ways. You can take medicines to stimulate the white blood cells, but you can also take medicines that directly attack the actual parasite. It just depends on what it is that you're taking. Most will directly attack the parasite. That's an antibiotic, a macrolide antibiotic. It typically works against bacteria, but that attacks the thing directly. That's a macrolide. So finally, we get to basophils. Basophils, remember, are the most rare of our white blood cells. You have to really look for them in a blood smear to find them. They represent less than 1% of your circulating white blood cells. Basophils are granulocytes, right? They're filled with granules. And when we identify them, we can identify them by how dark they are. Their granules are incredibly dark. They stain very, very dark bluish purple. They're the only ones where the granules are darker than the nucleus. Normally the nucleus is the darkest thing in the cell, but when we look at basophils, their granules are so dark that the granules are actually darker than the nucleus itself. It's the only time you'll see that. That tells you that it's a basophil. Basophils are not phagocytes. Okay, they're one of the few white blood cells that are not phagocytic. When we look at basophils, we see that they tend to accumulate in damaged tissue or sites of infection and promote inflammation. Okay, so basophils are highly inflammatory. They cause a lot of pronounced inflammation. And they do this by releasing histamine, right? And I'm sure you can kind of associate histamine with inflammation, right? Or like allergies, right? What do you take for allergies? Antihistamines, right? You try and block histamines because histamines, and then what happens during a really severe allergic reaction? You blow up, right? You swell, inflammation occurs. Histamine, amongst other things, it causes runny nose and sneezing and watery eyes, but it also causes a lot of inflammation. Okay, so basophils cause inflammation by releasing histamine. Okay, they also release heparin, and heparin prevents blood clotting. The thought here is that the histamine dilates blood vessels. Dilates means like makes bigger, opens up. So the histamine opens up the blood vessels to bring a bunch of blood to the area, and the heparin makes sure that blood doesn't clot, so it keeps flowing nicely. And the idea is if you bring a ton of blood to the area, you can bring a ton of white blood cells to the area, right? You're kind of rushing all the defenders to the area. It also increases the permeability of blood cells so that the white blood cells can easily cross out of the bloodstream and into the periphery. That happens to cause inflammation as well, and that kind of, again, it forms like a barrier or kind of limits that area and kind of walls it off from everything else so that the infection doesn't spread as easily. So that is protective. Painful, but protective. Whoosh. So we talked about what a differential is a little bit. Remember the differential is a blood test? And this gives us the number of each type of white blood cell in a sample of 100. So what is that essentially giving you? The percent, right? However many in 100 is the percent. So it gives you the percentage of each type of white blood cell. And we know what the normals are, right? We have these ranges that are the normal differentials for the different types of white blood cells. And we can look at this to detect changes in white blood cell populations. And this can actually give us a lot of information about what's going on with the patient. If the white blood cells are just high, if they're moderately high, we think, okay, infection, right? Maybe inflammation, but probably infection. If they're super high, we start to think of like cancers, like leukemia. But that only tells you so much, right? They're high, infection, okay, now what? If you look at the specific white blood cells and the changes in specific white blood cell populations, that can tell you more about the specific infection. So again, parasites and eosinophils go hand in hand. So if your eosinophils, instead of being 2 to 4%, are now at 8%, you have way more eosinophils. You're very likely to have a parasitic infection, or perhaps there's an allergic response going on. So we can kind of monitor. Lymphocytes tend to go up with viral infections. Monocytes do as well. Neutrophils tend to go up in bacterial infections. So we can monitor the different types of white blood cells to try and give us hints as to what exactly it is that we're looking at, what type of infection. As always, we have a couple disorders that we'll look at. What does penia mean? Small, it means poverty. Penia means poverty, right? So you don't have enough of something. Leuco refers to white, right? So leukopenia is a poverty of white blood cells. This is an abnormally low white blood cell count. So for some reason, you don't have enough white blood cells. This occurs during chemo. Chemo kills all of your rapidly dividing cells. So it also happens to kill your blood cells as they're developing in the marrow. So that causes leukopenia. Also, radiation causes leukopenia. Some meds do, like we give drugs called immunosuppressants to treat some autoimmune disorders like rheumatoid arthritis, some skin conditions, some IBS, but immunosuppressants would also cause leukopenia. HIV, AIDS, would cause it because HIV or AIDS is actually a disease of your lymphocytes. So your lymphocytes are diseased, you don't have enough of them, and that leads to a low count or leukopenia. And then there are some anemias. We have, I won't go into it because there's a bunch, but there's something called aplastic anemia, where it's a disease that causes leukopenia. What would a problem be with leukopenia? Right, weakened immune system, you're susceptible to infections, right? Your white blood cells defend you against disease. So if you don't have enough white blood cells, you can't fight disease. So things like touching a doorknob, being in an elevator, going to a crowded place become very dangerous. Even like eating fresh fruits and vegetables. When HIV patients have a really low, what we call CD4 count, eating fresh fruits and vegetables becomes very dangerous because of the bacteria that might be present on them. Okay, so it's really, really difficult to defend against disease or infection. Leukocytosis and leukemia are both elevated white blood cell counts. It's just the degree, okay? How elevated is it? Leukocytosis is a relatively high white blood cell count. It's a little higher than normal, right? Instead of 10,000 cells per microliter, maybe it's 15,000 cells per microliter, or 16,000. It's relatively elevated. And that typically just signals infection or inflammation. There's some sort of infection present, and your white blood cells are multiplying to fight it. Pretty normal. We all have this happen at times. Not a big deal. Leukemia is an extremely high white blood cell count. Very, very, very ridiculously high white blood cell count. This is actually telling us that there's a cancer of the bone marrow. So can you tell me, like in general, what happens in cancer? What do the cells start doing? Rapidly multiplying, right? It's like their controls go off and they just start just dividing like crazy. That's how you get a tumor, right? The cell doesn't know to stop. It just starts dividing. And it divides so fast that it doesn't actually develop. It doesn't like differentiate the right way. So you just get a ton of kind of blank cells that don't do what they're supposed to do. So with leukemia, the cancer is actually in the bone marrow. So these stem cells that are supposed to become your blood cells start dividing like crazy until you get tons of them. You might think, all right, well, great, I got a bunch of white blood cells, I can fight anything, but they don't work. They divide so rapidly that you get a bunch of like blasts or baby cells in the blood and they're not differentiated and they don't work appropriately. So you actually don't have a good functioning immune system when you have leukemia. Okay, so we finally finished part 2 in class.
So can white blood cells move through the capillaries the same way that red blood cells do?
Yeah, they can.